Hey, what's up, everybody? Welcome back to Nursing Uncharted, a space that explores the rawness, the realness, and the boundless possibilities of nursing. I am your host, Maggie Reichard, and thanks so much for tuning in and listening to us today. We've got a great show today, one that I am particularly excited about because it is a realm of nursing that a lot of people, that's getting a lot of traction. A lot of people are interested in it right now. It's another procedural area, and that is endoscopy. And I have the pleasure of having one of my best friends here today to tell me all about her job and what it's like to work in endoscopy. So here to delve into endoscopy with me is Shelby Evans. Shelby began her nursing career on a large inpatient bone marrow transplant and oncology unit. She experienced nurse burnout early on in the inpatient setting, and after a couple years, she started searching for different roles within the profession. For the last 5 years, Shelb has been working in endoscopy, acting as charge nurse, and assuming leadership roles within committees that work on unit improvement and employee engagement. While procedural areas were closed last year, Shelb has also helped form a COVID phone line to triage patient care at the beginning of the pandemic. Shelby lives in Colorado with her husband, Matt, and their dog, Zeppelin. So, Shelb, welcome to the show.
Thank you.
Shelb and I have podcasted before together, so it's nice to be back doing this with you again.
Yeah, I think it was your first episode when you were traveling in Denver.
Yeah, I know. Yeah, it was a different setup now. We're doing zooming. It's a different type of podcasting than it used to be.
Yep. So, well, thank you for introducing me. Endoscopy has been great change of realm, and I recommend to anyone that is feeling they need a change of pace or different work-life balance or things like that. It's a great avenue, and it's a different specialty, so you can learn a lot more about a certain aspect of the human body, and patient setting is a little bit different as well.
Yeah. How is work right now?
Currently stressful. I would think a lot of people would probably agree, but we've actually canceled a ton of our procedures. So we're doing only about 20 patients a day. Normally we do about 80 patients a day, but they have nurses being redeployed to different areas, whether that's a standalone surgical center just to free up some space in our hospital, or they'll send us to inpatient units as well as the anesthesia. The CRNAs have been super helpful in the ICUs. So just with our capacity issues right now, it's been a little more hectic and kind of just going with the flow of whatever the day holds.
What did they cancel? All elective, and now they're just staying
pretty much elective. So yeah, we are currently doing patients. They consider them tier 1, meaning if they don't have these procedures, they could be admitted to the hospital. And then any patient that is a tier 3, so very healthy, non-urgent, are being sent to different healthcare settings just in case they need to utilize our space for inpatient areas. But they plan to go back to our regular, more routine stuff beginning next week. So this has been about 3 weeks that we've been on this holding area. And then it just seems like it's going to keep fluctuating depending on how things are going.
Yeah, dang. So I'm guessing in Denver, the cases are popping up a little bit more right now?
They've been kind of high since September. And then we just never had that plateau. It just seemed like it kept climbing. So I think it was once the holidays are starting, they were just really having issues with capacity. So.
Gotcha. Okay.
Yeah.
So when you say, are you trying to free up space in case you need to board people in those areas, or are we just shutting down to prevent transmission?
So a little bit of both. They're preventing any admissions. So a lot of the procedures we do are pretty straightforward. Patients come in day of and they go home same day. But some of them are more complicated and they require admissions to the hospital. So those procedures, there's not room for those patients unless they think this patient would be admitted to the hospital otherwise. So we're trying to cut down on admissions, but in addition to that, they were using our space for a short period of time with inpatients in our actual procedure rooms. So they installed call lights and it was kind of a cluster. They installed Pyxis and things. They had one nurse float down there from inpatient, and then she was supported by either an educator, or one day it was my manager, but just different people were trying to help fill this role.
Gotcha.
So it's just been changing week by week. But yeah, I think main thing is space and decrease admissions.
Gotcha.
Just so that we have space for people that come into the emergency room and we're not holding there.
So the patients that would come in and when they were overflowing in your unit, it wasn't you guys that were staffing those? It was a inpatient, was it a GI
Sometimes.
Patient?
No, they were not GI patients. And the plan was that it would be short, it would be an observation patient so that they would come and hopefully get discharged same day. But that didn't always pan out well. So they did have us staff it for a couple weeks. But it seems like mostly they're utilizing our educators throughout the whole hospital to staff as a support system for these inpatient nurses.
Gotcha.
To try to cut down on making other floors short. But at the same time, some educators have left the floor many years ago and aren't the best support sometimes for these inpatient nurses, whereas other ones are more recent and they know the logistics of how everything works. But it's just been interesting. We had a family member come out of one of the rooms the other day. And she was like, "We're out of oxygen." We were like, "Okay." This place has oxygen flowing from everywhere you can think of. It's coming out of the walls.
We're out.
And she went to grab our oxygen tank off of our code card. And we had to be like, "Ma'am, that one cannot leave that area. That's an emergency oxygen tank. Let me show you where it is in your room." But just interesting things where it's and then you have patients coming in for procedures and they're like, what is happening? I
can't imagine trying to be a patient. How does this unit work? And we're like, we
not
don't really.
Yeah.
So right now, oh man,
been a little bit of a cluster, and just, I don't know, people are sometimes understanding and other times are not, as everyone's dealt with. So just dealing with those logistics.
Yeah, I mean, the past 2 years has just been a test of how well you can accommodate change, across the board. It's all right,
for sure.
This new different thing, we were, saving all of our masks and now we're throwing them all out. Oh, we got to save them again.
Right. Oh, we're just out of that mask. You're like, what?
Yeah, we're just out. Oh, we changed to this thing that looks completely different. I had we're running out of there's medication shortage supply, with so many different meds. Heparin is out, and I was going down for a imaging for one of my patients, and you have to bring down epi and atropine whenever you go on a trip. And the atropine syringe was different. The box was different. And I was like, is this the right thing? I need to know that this is the right thing. Because I can't just, what if it's not? And there was a pharmacy tech that was in there. I was obviously looking at it. I'm am I actually, is this right? She's like, yeah, it's a different manufacturer. We had to switch the other ones out. But it's okay. Just look right.
That's scary because epi is a very important medication and you don't want to be administering it incorrectly.
Right. Yeah. So
we ran into that shortage as well as normal saline, the flushes. they're saying that we need to be like mindful and careful of those. I think a lot of it has to do with like the shipping and just manufacturing across the country. But it's interesting how it's affecting healthcare, because when you're a nurse, you're like, when you need something, you need like that.
Right.
Thing. I mean, so it makes it a little tricky. You have to get creative.
It really, you do have to get creative. And it's like, you have so many things that you have to do in your day. It's like, these are just like curveballs that you're being thrown. And then you're like, have to dodge things and like, just like keep going based on, it's something that you don't anticipate and that you don't. But I guess like we all have to nowadays. It's just part of it. Like, I feel like I get 5 emails, like at least 5 of like changes that are happening, like a day. It's just,
for sure.
It's just how it is now.
We do seem to have less changes in a clinical setting than you do on the inpatient setting, because I do remember that being a little bit of a part of my burnout, because it's like I'm already working to my max capacity, emotions are high, everything is like challenging, and then you're on top of that getting those 5 emails a day of things that we're implementing or doing something different, which just complicate your day-to-day work. So I do remember that being like beneficial to going to the clinic. But in this last 2 years, we've had like the most changes I've ever seen down there prior. So just trying to like keep everyone's morale up and like, this is just 3 weeks and then we'll be back to like our normal. Because a lot of the nurses that have came to work for us don't want to work inpatient anymore.
Yeah.
And now we're redeploying them to those areas. So as a charge nurse, I'm trying to help like listen, but also be like reassuring, like you chose like this job, you enjoy this job. It kind of helps you appreciate the job a little bit more too when you're thrown into an area that's uncomfortable or maybe not what you necessarily want to be doing.
It's like they had, people get PTSD or just like, they're burned out from that job, and they're like excited to go to endoscopy to do something else and like have less of maybe stressful job. And then you're like, oh wait, you got to go back just for a little bit. And then you could come back, but we need you over there right now. Like, that's gotta be frustrating.
So trying to like boost our morale too, so that we in turn don't lose staff as well, because that would be a bummer.
Right. Do you remember what you were looking to leave behind when you left inpatient to go to endoscopy?
Simple things like just alarm fatigue. I just remember like coming home after shift and I would shower and I'd still hear noises beeping. And it's like so simple, but that another thing was living with he was my boyfriend at the time, but we would go like sometimes 2 to 3 days without seeing each other. And I was like, I just want to be able to come home and like have dinner together, like simple as that. But I was just like, he would work longer days and then I would go in for my night shift. And then by the time I came home in the morning, he was already gone, which was fine for like short periods of time. But it felt like we were going lots of periods of time where I was either working a whole weekend or during the week, we just wouldn't see each other much. And I just wanted a little bit more like routine life. I don't miss the feeling after a night shift either. You're just that lag. So before I did go to endoscopy, I switched back to days for a short period of time, just to try to, rejuvenate and get back out there. But bone marrow transplant patients too are quite difficult in the sense of their whole world is flipped upside down. They're there for months on end. And as the inpatient nurse, you're only seeing when they're not doing well. So I was creating a lot of really good relationships with my patients, but then they would pass away. And I had a couple towards the end that like hit me really hard. And then the ultimate, like I pulled the cord of doing it was my grandmother was diagnosed with leukemia. And then everything was way too close to my outside life, my work life. I remember like going into work crying before my shifts and like nothing had even happened yet. Like it was like anticipating
all in your head.
Correct. So I was like, I'm good at what I do. I like know what I'm doing, but I like clearly don't like my job if I'm crying before I even start it.
That's such an amazing, like, because you're exactly right in the sense that like you're good at what you do, you like your patients, but then like there's such a disconnect there because like it's really has such a heavy weight effect on you, but you can like deflect yourself from it to a degree, like you just realizing like those two, something's got to give.
Yeah, and I think an important thing with that too is like, you know, some people do a great job. Like I have friends that still work on that unit and have been there for like 7 years. But it's also finding the right balance of your work-life balance. You really have to take care of yourself and make sure like you as yourself are taken care of in order to take care of your patients. So I don't think you can't not do it. I just hit a point where I realized it wasn't a good fit for me, like at that time in my life.
Yeah. I think that's something to be said too, because I mean, a lot of people can do hospital inpatient life and they're good at it and they don't mind it. And sometimes it just takes a little bit of, you know, change of scenery. Like for me, I was burned out in acute care, and right now I really like being in the ICU. It works for me, even though I don't have that like, you know, work-life balance. I do like miss out on seeing, I don't know, there's just like kind of I'm not as bothered by it, I guess, as I used to be. So I mean, and I have friends that, you know, are great in acute care and it doesn't bother them like it bothered me, you know, some of those things, but, you know, and good for them. I think it's just all about figuring out what is going to, you know, make you happy.
For sure. And I think too, being a younger nurse, that work-life balance was like a priority for me, but I would agree with you as like, if I was to go back to those similar shifts now, it wouldn't affect me as much. Like, I have to do a couple of weekend calls a year, like 2. It's like, I don't even count it if people ask if I work weekends, but if I had to work a weekend now, it wouldn't affect me like it did then. Like, it just wouldn't bother me as much, but I still do enjoy the time that I have. You know, when I am cooking dinner with Matt, I like really appreciate that time because I remember not being able to do that.
Yeah, right.
Simple things like that. I'm just like, ooh, it feels good to be home. But you're right. Like at this stage in my life, I wouldn't care as much about committing to a more flexible schedule. But at the same time, I really like my team and I found something that really suits the best of both worlds for me. So I'm happy where I am.
I think that I don't mind working weekends anymore. Maybe it's just because we're older and we just don't really do as much on the weekends. Right. Like, you know, when you're younger and you're like young 20s and you're like drinking and hanging out with people and, you know, you're like going away for the weekends and stuff. I feel like you just have FOMO all the time or like working nights and stuff. I mean, I just remember being so upset when I had to sleep during like a beautiful day and everybody was out at the pool or something and I was inside. I don't know. It doesn't affect me the same way. I mean, I don't like working every other weekend because I work every other weekend, but you know, I don't know. It doesn't have that same like, pull that it did 5 years ago. I know
exactly what you mean because you would hear people like playing music on a Friday night and you'd be getting in your car to like drive in for your week shift. Like it was your work week. And it used to bother me so much because I was like, they're just over there having a good time.
I know. I'm not as bitter about it.
Exactly. But I think that comes with time too.
Yeah. And I'm sure it'll come back, like, you know, when we have kids or like, you know, you want to be able to like spend time with your family when people are off, but.
Yeah. And we see that in our clinic too. Some people really just like trying to get away from the inpatient realm just to spend time with their kids, which is such a simple thing that a lot of people don't think of in other job realms, I feel like, but it's like you only work 3 days a week most of the time. But however, depending on how those hours fluctuate, you really can miss like a lot more time with family.
Yeah. Well, and I mean, especially in working nights, I mean, if you're inpatient, it's like you need that extra day to like flip your nights and days. And also just, I mean, I feel like I can't do anything. And it's like such a crappy day because you have like this laundry list of like, oh, in the last 3 days, I didn't do dishes or laundry or vacuum, and I have a golden retriever, or like, you know, there's like all of these. It just takes extra time. You're totally right. So it's like you don't have. I mean, you're home, but like, I don't know, you don't have the same energy that you could like put into your family and doing things. We'll be right back to our interview. Grab a cup of coffee, but don't go anywhere because we want to talk to you about our podcast partner, American Mobile. No matter your specialty, American Mobile has endless travel nursing opportunities. With the largest clinical team of all staffing agencies, American Mobile is ready to support you in achieving your career goals. To learn more about the benefits of American Mobile, like higher earning potential, premium health coverage, and 401k matching, make sure to visit AmericanMobile.com to speak with a recruiter. Again, visit AmericanMobile.com to discover your next travel nursing adventure. Now, back to the show. Do you feel like, you know, when you were thinking about what you were leaving behind in inpatient, or do you feel like you found what you were looking for in endoscopy?
I do. The only thing I would say that I miss are those interactions with my patients, like those relationships that I did create. My interactions with my patients are still great. They're just very short. So I'm either pre-oping them, recovering them, taking them to their procedure, but it's typically like 30 minutes to an hour that I'm spending with these patients. Some of them routinely, regularly come back to us. But it's a little bit different where I'm having like smaller impacts on these people's lives. Whereas when you're in the MICU or you're in the inpatient, like you really feel that difference that you're making. So that would be something that I would say I still miss or haven't totally figured out. But where I work now, I would say I like the complexity of it. So for the endoscopy lab, we have about 8 interventional or therapeutic doctors. So they essentially perform like less invasive like surgeries through an endoscopy scope, or they'll perform like a ERCP. So for people that have pancreatitis, they diagnose cancer a lot of times, which that can be hard, but you're that first person that's there with them when that's happening. And then we still do routine upper endoscopies and colonoscopies. But since we're connected to the hospital, we do inpatients. So we go to ICUs, step down patients come through our lab. We see inpatients, whether it's a food impaction, someone swallowed something they shouldn't have. We see a decent amount of people come from jails, so like inmates and things like that, that have maybe swallowed something they shouldn't have. So it just makes it a little more interesting because I feel like our lab as a whole, we see a lot more than a typical endoscopy lab. So I like the idea of being attached to the hospital because I get a little bit of a mixture of everything. So sicker patients while also seeing a more routine patient. I recently picked up at one of the surgical centers. They asked me to float there with all these changes. And they were all tier 3 patients with like no medical history. And it was good. I was like, this is nice. But it was like very straightforward.
Cut and dry.
Not a lot of change. Yeah. Like I was just like, oh, like my job is more exciting than I realized, like compared to other, like I was like, I'm not ready for that yet. So we typically have about 10 procedure rooms running a day. And then we'll do anywhere from like, I don't know, 2 inpatient add-ons all the way up to, I've seen one doctor do 16 in a day, which was insane. But It just varies day to day. And then adding in being a charge nurse really helps because if any issues or problems come up, like I'm the go-to person to try to solve and figure out, like, how are we going to make this work? Or should we wait till tomorrow? So,
right. So, like logistically for people that are maybe interested in looking at endoscopy, what is your day? Like, how do you normally set up your day? What does that look like?
It depends where I am. So, pretty much every day of the week, I do something different. Whether that's I'm charged a lot of my shifts, so I can be charged in pre-op, I can be charged in recovery, in a luminal area, which is our more routine procedures, or in our therapeutic area, which is our more advanced procedures. So depending on the area, it kind of switches up what I'm doing. Pre-op and PACU, though, is essentially supporting my nurses as well as anesthesia. So making sure everyone has the things they need to perform their tasks for the day, or if they are unable to do something on their own, being that like extra resource for them. So I like that role because it's just constantly changing depending on what people need. Whereas if I'm in the other areas in the procedural side, I'm more so delving in with the physicians, fellows, nurse practitioners, or PAs, trying to figure out a plan for the inpatient that are sick and need to come down while also still supporting your nurses in the room. But you're more so working to collaborate a plan for the day, reaching out to inpatient nurses to figure out what else the patient has going on. Can they come down for the procedure, things like that. So it just depends. But I like the role of charge nurse down there because I get to interact with everyone on a day-to-day basis, even if it's for short periods of time. But I'm more involved with my staff than I am with the patients. Whereas if I'm acting as a pre-op nurse or procedural nurse, I can interact with the patient still, but I get a little bit of everything.
Is there one charge for both the procedural areas and pre-op and PACU?
So we do have permanent charges in each of those roles. And then I'm a relief charge. So I get to fill in when those charges aren't there, which I actually really love because then I get to work in all the areas versus committing to one specific area.
Okay. So there's floating, but like in one shift, will you have like 2 or 3 charge nurses, or will you just have?
Yeah, we have multiple.
So
there's one we'll have typically 4 a day, which is a lot.
Okay.
But with the 80 patients we typically see, that's like, you need that to run efficiently. We have about, I want to say like 50 staffed nurses. In therapeutic area, we'll typically have anywhere from 2 to 8 nurses in that area. Same with our luminal area. And then pre-post, we typically have about 14. So in a given day, you have a ton of staff, like close to 30 staff that you're trying to help coordinate things. So it's really helpful to also have the additional charge nurses to go to if you're not sure what to do. Yeah.
I remember I did endoscopy for like 3-4 months as a traveler. And I remember, I had just so much respect for the charge nurse because we had maybe 6 rooms going at one time, but it was like trying to figure out where the anesthesiologist is going to go, like what nurse is going to go. Like, I think the nurses and the techs maybe stayed in the same room, but then sometimes something would get flipped and then you had to change things around, or like, this inpatient, you just stick the inpatient wherever, you have space, or it seemed like such a complicated, so they were like playing Tetris with patients on the screen.
Well, it's interesting too, because we have a lot of equipment, and so equipment malfunctions all the time. So then people will go to their chargers and be like, what do I do? And so just being able to tackle that too. But it's funny because like some of it, I'm like, okay, that's easy. I can figure that out. Other times, you just need to know your resources, who to call to help you figure it out. But if the patient's on the table under anesthesia during their procedure and something malfunctions, like you have to have like your plan B ready to go. So we've had to switch procedure rooms in the middle of cases occasionally. That's not ideal, but you have your attending, you have your fellow, you have 2 nurses, you have anesthesia. Sometimes anesthesia is teaching someone. So you have a lot of bodies to help you when that arises. It's just like the switching a room when someone's under anesthesia is like definitely not ideal.
It's just not it's just not what you want.
Correct. Yeah. It's not what the patient wants. It's not what the staff want, but we have had to do it. Just one of our physicians does laser equipment, which is really cool, but they use this really small fiber optic laser to go into their pancreatic ducts and break up stones. So he has his endoscopy scope, but within the scope is another scope with like a very small camera that goes up into the duct. And then through that baby scope is a fiber optic wire. So there's so much equipment involved in that said procedure. Like things aren't always going to work out well. Right. So in that instance, we have had to switch rooms before. It seems like the fiber optic can sometimes overheat, or I don't know, the power source is different from any other power source we use for other equipment. So sometimes just changing that device to a different room, it will work properly. But at that point in time, you have to move the patient to another room, which is a lot of work, especially when they're under general anesthesia. So.
Yeah. And it's such a complicated device, it sounds like. So I'm sure there's no way to troubleshoot it quickly in the moment. It's either you just plug it, take it out and plug it back in. And if it doesn't work, you have to scrap it.
So, and we will switch them out occasionally, grab a new one. However, since these are specialized equipment, they cost a lot of money. So trying to save costs, but also keep the patient safe. So we'll typically go through one, if one breaks, we'll pull out another one. But if it breaks again, we're okay, well, maybe it's not the actual device, something else is going on. And then we'll go to the next plan. It doesn't happen all too often, but we'll also notify the company. The company will come out and watch. It does seem like whenever we contact them, though, everything goes fine. It's of course, you're here. It's not doing what it normally does, or it's performing like it should. So that can be tricky. Sometimes we've contacted them in the middle of a procedure and be look, this is what it's doing. To show them in real time, we're this is what's actually happening. So.
So you said in the room, it's the attending, the fellow, the anesthesiologist, maybe somebody that they're teaching, and 2 nurses and the patient. And
it's typically a CRNA instead of an anesthesiologist. So a CRNA could be training. We have a AA program at our hospital, which I had never heard of. It's Anesthesia Assistant. It's a similar concept of a CRNA, a shorter program though. I think you are required to have a bachelor's degree, but you don't necessarily have to have a background in medical, which is interesting. Idea, but they are a lot of times trained by another AA or a CRNA. So we almost always have anesthesia assistant student also in the room, as well as a CRNA. Not always, but sometimes they can't practice exactly the same as a CRNA could. CRNAs can work at their own clinic and they can perform stuff on their own, whereas AA has to be under an anesthesiologist. So
I feel like you would have to have a chemistry background or something.
They do need to, their schooling, they have to do organic chem and things like that before they start. So I think there's 5 or 6 prereqs you have to do before the program. And it has to be within a certain period of time. So even if you did it years ago, you might have to retake them. But.
Gotcha. Okay. You didn't say endoscopy techs. Do you have any endoscopy techs in the room?
We do. The endoscopy techs, though, in our facility are in our luminal procedures. So doing the upper endoscopies, colonoscopies, they'll assist with liver biopsies. They also act as our sterile processing. So we have sterile processing in our hospital, but our own endoscopy lab, with the amount of volume we do, we reprocess all our scopes. So the techs will either work in our procedure room or they help sterilize equipment for us. So they're not in our therapeutic advanced rooms, which they can at some hospitals, they can work in that role. I think that we've steered away from that only because our physicians do a lot of new things. They're always trialing new equipment, doing new procedures that it might be new research. So I think the doctors specifically want that additional support. We do give a lot more medications too in those procedures, which they wouldn't be able to administer. But comparative to other hospitals that have these interventional roles, a lot of times we're getting them transferred to us because they can handle the difficulty of it and things like that.
Gotcha.
So I think that's more of I don't know if other areas operate like that, but we do have endoscopy techs. They're just in certain rooms and not in other rooms.
Gotcha. Yeah. Because I know, just based on when I used to work as a traveler there, that endoscopy tech is very different than inpatient tech. It seems like you have definitely, there's a difference in responsibility. I guess the roles are very different. I felt like the endoscopy techs were very hands-on, in the procedures. Yeah,
they're there assisting the doctor, right side by side. I actually helped a fellow CNA I worked with on inpatient get a job as an endoscopy tech with us. I passed her in the hallway one day. She was crying. She had a horrible shift, and I recommended she apply to try something different. And she loves it. She's still there. So there's something for everyone sometimes.
Oh, that's cool.
Yeah.
That's awesome. So what does the nurse normally do in those procedures? What are you responsible for doing?
Yeah. So one of the big changes we've had over the last year is we moved away from conscious sedation, which used to be nurse administered, fentanyl Versed sedation. We moved to all propofol administered by CRNAs. So that used to be a role the nurses would perform, would be administering meds. But now they moved more into what's called a circulating nurse role. They're doing a lot of charting and documenting of what's happening during the procedure. They're also helping back the tech if they need additional equipment that maybe isn't in the room, or grabbing them things. And then the CRNA, they're helping them with their turnover. So cleaning their equipment off, changing their suction, they're wasting the propofol medication after the procedure. So just helping things run more efficiently. And then the tech is, helping man the scope and the equipment. So that's typically how it goes. In our therapeutic rooms, we have 2 nurses assisting the doctor, and they essentially alternate in those roles. Okay. But if you're the nurse that is acting as a tech, you're assisting the physician. So you're handing him the tools he needs, whereas the second nurse is grabbing you things that you'll need to perform that task. They use a lot more equipment in those rooms. So it's nice when you're actually, handing a physician a wire, they're having you inject contrast or inflate a balloon. They might want to dilate after that. And your other nurse is setting that all up for you so that you're able to just switch out the equipment and hand the next equipment. So just helping with efficiency. It is nice to have 2 people in the room to help with those things.
Yeah. So you probably have to learn all of these different types of procedures and in preparation for what they're going to need and stuff.
For sure. Yeah. It's a whole new realm. And it's not something that you would typically come in knowing unless you had prior endoscopy experience. And with everything that had happened with COVID, we lost probably about 50% of our staff, whether they left nursing altogether, moved home to be closer to family, changed career paths to do something else that they want to do. A lot of people saw people making big changes. And so trying to get our staff all retrained and like up to what expectations are it's challenging because I would say the only place that nurses really come in feeling comfortable or like feel like they understand or know from prior experience is typically our recovery area. You know, you're used to that interaction with patients. You can learn what you can and cannot give the patient based off of your orders or asking another fellow nurse. But the rest of the area is like brand new for everyone. And I don't know, I think that's what makes it exciting too.
Yeah, definitely. I mean, it's a brand new change of pace for people that are looking for something different, you know?
Yeah, for sure.
I know you are seeing more nurses come from the inpatient setting to outpatient, like you did. Is it do you feel like it is a difficult transition to go from inpatient to outpatient?
Wouldn't say it's difficult. I would just say it is like a vast change. And one of the things that I worry about sometimes is not fulfilling other nurses' like abilities. You're doing different roles. So, you know, the teching role, it's just a different change from what you would normally do. So I guess I worry, I hope they're not just going through the routine of the day, you know, clocking in, doing their tasks, leaving. Like, I want it to be interactive. I want them to feel like useful, helpful, things like that. Which I do see sometimes there's nurses coming straight from inpatient that maybe weren't ready for a transition, but came for the change in hours. So maybe they're not burnt out, but they want the better hours. I feel like they more so miss the like hustle and bustle and like chaos of the floor, because we still have chaos, but it's like organized and like more calm, and you have a lot more resources there. Like we have an anesthesia attending in our pre-op area at all times, so if you had someone with an extremely difficult IV, they're right there to support you. Whereas on the floor, you could wait a whole 12-hour shift and not have a patient with an IV because you're waiting for a resource nurse to come. So there's just different levels, and then you give less medications. So we still give some, but that's like a massive change for some nurses. Like they just feel like they're not, I don't know. It's not that you're not there for the patients or caring for them, but it's like that simple thing is different. Also, when you're in the procedure room, the CRNA or AA is monitoring the patient. So the vital signs, like it's not on you, which I think some people really miss, that being in charge of the patient care, not as a team, but like it's their like top priority.
A lot of the responsibility for the patient's well-being and care is now dispersed, whereas it all falls on you, essentially, you know.
Like you're the messenger, you're the middleman. Like if something's not right, you need to be doing something to notify someone, which you still do. But normally there's another person or like provider overseeing what's happening.
It's a shared responsibility.
Which I enjoy, but it is like a team dynamic. You're working very, very closely with your staff. So if someone else is not having a great day, you're feeling that. So I feel like as a charge nurse, my main thing has been like morale and, you know, listening, but also still like trying to put things in perspective, which I actually have appreciated us all having to float back to inpatient, because I really do feel you forget it really quick. Like you remember the like aches and pains of it, but when you're physically doing it, you're like, oh yeah, I love my job.
I think the switch in like, you know, just setting up your day from being around your patient all day to now being around your like coworkers and staff. I'm sure that's, you know, like when you're a charge nurse and you're putting out fires, before it would be like putting out fires with patients and family members and stuff. And now it's probably putting out fires with like morale with staff and like communicating with the different like attendings and fellows and anesthesiologists and stuff.
For sure. And that's, everyone has different personalities, different expectations. So trying to find a like clear, like even level playing grounds for everyone.
Yeah.
But overall, we do have a great team, and people are hardworking, and they are there to like perform their job well. So that definitely helps make my job easier. And occasionally you're still putting out the fires with patients. We recently had a patient come in, and I don't know if it's like this at your hospital, but we have limited visiting hours still with everything with COVID. So at 8, you're not typically allowed to have visitors. And then you can only have one visitor per 24-hour like period day. So you can't keep switching who's coming in and out, which is hard for these patients. But we had someone in our waiting room that was planned to be admitted, and he was demanding that both of his family members had to come back with him to pre-op procedure. And then when he was admitted, they were going to stay overnight in the hospital. And we had multiple people we had to involve to just have a conversation with him and his family. They didn't want to hear our reasoning or logistics. They didn't care. They came from like 4 hours away, and his daughter apparently didn't have anywhere to sleep that night, and they didn't have any family in the area, and it just kept escalating to the point where the family and patient were being very aggressive towards our staff and our manager. And we had to contact the command center to have one of the nurses go over, because he said he had it approved, and just all these logistical things that I feel like you're used to dealing with patients and trying to de-escalate a situation. And it came down to he had a disability that allotted him a caregiver to be with him at all times. So he did get approved to have one person stay with him overnight. But I don't know like what her exact role was. She was part of like patient placement, dealing with putting out fires across the whole hospital. But she came down to speak with him briefly to go over our expectations as well. And I haven't seen that happen very much. I feel like we all, whatever the patient needs, we support them. We take aggressive behavior, like all these negative things that we shouldn't be doing. And she pretty much put him and his family in line and said, we can provide you with that caregiver. It doesn't necessarily need to be a family member. Like we can provide a staff member here at the hospital if you're not going to be treating us appropriately. And they, of course, were like, we didn't do anything wrong. Like we would never be aggressive. And she just responded that they were being physically like aggressive, verbally to her right now. And that she wasn't going to tolerate that behavior towards her staff here at the hospital. So we could revoke it at any time and provide them with the like care that they needed from our standpoint, which I really appreciated, because you don't see that happen too much, where your staff is really supported in patients maybe acting out or not acting how we would like them to. So I thought that was pretty cool. And then after it all said and done, we're taking him up to his inpatient unit, which unfortunately was like an overflow unit because we're to capacity. Family member would have had like a chair, like it's not a regular room, but they hadn't even made it out of our PACU. And they were like, you know what? We're actually going to go home. My relative lives right around the corner. So it was like this whole fire erupting, and it probably is a lot of anxieties that, they're dealing with, and they just are taking it on you for whatever reason.
Yeah, but like the fact that I would have absorbed all of that, like all of it. And then they were like, actually, nah, we're good.
We're actually good.
That would have stayed with me. Oh my God, I would have been.
Yeah.
I'm glad that you guys had that person though, to like back those situations.
Yeah. So I think, and a lot of hospitals have resources like that. It's just like, are they available? What else are they dealing with? Are they willing to come talk to the patient? Like, a lot of times they're putting out so many fires that they don't have that time to come down and speak with them. But I thought it was it was really nice, because then when the family did decide to leave, it was like, well, at least it wasn't just you arguing with them that whole time.
Yeah.
Somebody else was helping you deal with the whole situation. So,
well, and it's nice to have somebody that is just there and trained in those specific situations, because it's like, that's just something that you learn as a nurse, and like, you're not always good at it. I'm not good at that stuff. I like visitor restrictions when people want to come into the hospital. Like, I hate having that conversation, because if it were me, like, I would want to be with my like family member, you know, like when I have to push policies, it's like, this is just what we have to do.
I know.
Like, please don't fight me on it.
Someone recently, I was taking them back up to their floor, and it was like 6 or 7, and the family was with them, and they were like asking if they could stay the night. And I was like, you know, our policy says no visitors after 8. And they're like, well, I stayed the night last night. And I said, it kind of just depends who your nurse is. Like, as I just don't make much noise, stay quiet, they probably won't ask you to leave.
Hide under the bed.
But like, we all get that because we're compassionate. You know, you wouldn't want to be in a hospital bed by yourself. But these are things that we put in place too to keep patients safe. So it's we don't know if the family's vaccinated or what they're, you know, what else they have going on. So it's like we're all focused on the patient and the other patients surrounding. So that's really why it's set in place. But at the end of the day too, you want them to have that support person. So I was like, I don't know. Well, I was just told them, like, it depends on who you have. Like, they can ask you to leave though.
Yeah.
So just to like set that expectation, like, you might not be able to stay.
Yeah. And I mean, that's where you can get manipulated too. Like, when the policy is wavered at all, it's like, well, now this is broken.
This other nurse did it.
Like, now, right. It's like, now we have no grounds to stand on, and we look like, you know, terrible because you've already like blurred the lines. So
it is hard sometimes though. It's hard to know like when it needs to happen this way, or when you can.
And you're right in that, like, we're all compassionate, you know, that's why we're here. So it's like having, you know, some things set in place, like, you know, during COVID when you couldn't have visitors, like, that's heart-wrenching for us.
Right.
You know, but I think sometimes that's like where you're manipulated the most, because we're such compassionate people, and then people just want to bend the rules however it makes them, you know, because they think that they're entitled to bending the rules. And like that I think is one of the things that like made me really burned out in acute care, because you deal with that so much more. I think that in the ICU, like, lines are more like, this is what's going on. This is how, because how sick they are. And, you know, I mean, with COVID, like in the COVID ICU, obviously we can't have any visitors. And a lot of people are, you know, respect that. And we don't have that problem as much. But, you know, I think that was definitely a point of like strain and burnout for me, is like being so compassionate to the point where I was easily manipulated by people that were good at that.
Right. Yeah. I feel like I definitely have learned to set boundaries over the years, and it's something that you get better with over time. But then there's always that one person that really makes it tricky. You're like, how are you doing this? And it's hard to get yourself out of those situations sometimes, or like, not make them feel like they're not important. You know, they are important, or their needs are important, but arguing with them versus taking care of your other patients might be more important, but they don't always understand that, you know? So it just is a complicated personality and things. But I feel like every hospital should have support from leadership, and it's really nice when you can go to them. I know in our clinic specifically, our managers are always there for our charge nurses. So if we're trying to de-escalate a situation, whatever the thing may be, everyone needs to have a COVID test before they come for their procedures. Because we're putting them under anesthesia, we're doing endoscopies, and it's aerosolizing is essentially what it is. And so to keep everyone safe, they all have to have a COVID test. Well, every once in a while, we'll have someone that doesn't want to get one for whatever reason, or just hasn't, or didn't come back in time. So there's some situations where we're canceling or rescheduling. But our schedule is already so tight from, going up to 80 patients down to 20. So the next time they'll be able to get in could be months from now. So they've already waited. So there's all these things that are in play. And whenever we run into like tricky situations like that, I do feel that I also lean on my manager as, hey, I'm having trouble like talking with this patient. Can you talk to them? And we do our best too, if it was like an error on our part, getting them rescheduled like within that week. But if it's like something above our control, then at that point we like discuss expectations and like what we need them to do in order to be successful to have their procedure done.
Gotcha.
But it's nice to have
that.
Yeah, that extra support, because on inpatient floors, sometimes your charge nurse is too busy to handle those types of situations.
Yeah. Or it's almost like the expectation is like, she's too busy, or she or he is too busy, and like they really think like you need to handle it.
Yeah.
You're like, okay, but this is a lot for me. I don't know. I'm not going to do it well, or, it would like gives you a lot of stress and anxiety to like be the point person for some of those like really complicated issues.
Right. It also just helps reiterate, like, when you have that second point person, that you're not being difficult. This is the reality of the situation. Because sometimes I think that can be part of it too, is you come in for an appointment or you're in the hospital, and that day you're like, I'm just not getting along with my nurse or my aide or whoever it would be. So having that second point person be like, actually, this is what our expectations are, can really, I feel like, help change the patient's perspective sometimes too.
Yeah. Yeah, definitely, to have some, because I think that they probably also assume that whatever conflict is going to be escalated in some fashion. And so it's like, you need somebody to come and back you up, reiterate what you're saying. So I think we're going to wrap it up in a bit here, but just to pull it all together, do you think that there are like strong characteristics of a good endoscopy nurse that, if people are interested in endoscopy, they might, want to reflect on or consider?
Yeah. I think being a team player is number one. So working well with others is always something. If I'm sitting on an interview, I definitely look for in a person, just because we are working so closely with one another. It really helps to have somebody that wants to also work that way, like as a group effort, collaborating together. The other thing too that I would say is unique. I'm sure in the ICU you work probably closer with your doctors than you do on the inpatient floor, but you're right with the attendings during these procedures. So not being intimidated by your peers, they're there to help you succeed, and you want to be there to help them succeed. So sometimes, occasionally, we get nurses or techs come through that are really intimidated by attending, working that closely alongside them, but they really are there to help teach you and like help you learn. So if you had prior experience working really close with a physician, I feel like that would help. Of course, anyone that was in an OR or surgical PACU, it would be a very similar change. So that would be helpful as well. But we've had nurses come from all different backgrounds, from the emergency room, from educator physicians, from different ICUs, from different areas of the inpatient world. And I think that as a whole is what makes us run well and efficient, because everyone has a different thing that they specialize in. So if you're missing a supply or you're missing something that you need for your day to run successful, somebody probably has the expertise to know where to get that or how to do that. So that's really helped us as a whole.
Yeah, it's like a melting pot.
Which I'm like, I don't think you necessarily have to have any background to be there, but team player and like comfortable working with your physicians.
Peers. Yeah. Awesome. Well, this was great. Thank you so much for talking to endoscopy. about endoscopy with me?
Of course, yeah.
I felt very relaxed because I was like, well, I mean, I feel like I'm always relaxed, but it's different when you're talking to one of your best friends.
Yeah. Went through nursing school together.
I know.
Maybe I can get you an endoscopy in Denver.
Hey. Yeah. When I, I'm ready to do something else, or when I'm finally ready to move to Denver, where I'll go.
Yeah, there you go. I'm recruiting.
Yes. All right, Shelb. I'll talk to you later. Thanks so much for coming on. That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aiden Dykes for the music and editing. Until next time, take care of yourself.